Hello. Another 5 slides fix on the atrial septal defects. Let's get into it. So, ASD is a left to right shunt, which means that oxygenated blood is going into the right side of the heart and it's causing pulmonary overload. Its basic pathophys is that there is a hole between the left and the right atria, but it's going from the left to the right blood flow. It's going backwards. So, because of, again, I already mentioned this, because of the fact that the blood is flowing from left to right, it's causing an increase in pulmonary blood flow, which leads to pulmonary congestion, right side dilation, and the risk of arrhythmias and heart failure later on in life. Now, most of the time, 9 times out of 10, clinically, ASD is acyanotic, which means that these are pink kids. They're not going to turn blue unless there's enough pulmonary pressure to cause a reverse in the shunt where deoxygenated blood flow is mixing with the oxygenated blood flow. Again, left to right. Now, these kids are going to be asymptomatic in infancy, but it's going to start to appear in school age because they're going to run around. They are going to become short of breath, and so you'll start seeing those heart failure type symptoms. The other thing that you're going to see is a split S2 because of delayed pulmonic valve closure, as well as a soft systolic murmur in the pulmonic area. Remember, area is on the sternal border, second intercostal space on the left hand side. You will also, like I mentioned, see exercise intolerance, fatigue, respiratory infections. They'll get them frequently because of that pulmonary congestion. There's also long-term risk of atrial arrhythmia, stroke, and paradoxal emboli. A large ASD can cause in children FTT, again, heart failure signs, and hepatomegaly. For small ASDs, we're going to treat them by waiting, but being very, very cautious as well as monitoring it pretty frequently because they can spontaneously close if they're very small. If they have a large or a moderate ASD, the most common intervention is going to be transcatheter device closure. But if they don't have a suitable anatomy, they can actually do what they call a surgical patch repair. Medication wise, there's no routine drug therapy. We can use diuretics to help that excess fluid relief. And we can also, if they really, really need it, some sort of inhaler to help them with that exercise intolerance. But after the repair, we're just monitoring for any arrhythmias and any residual shunting. Nursing care is pretty straightforward. It's all about monitoring the subtle changes. So we're going to track their growth, track their feeding tolerance, and their respiratory status. We're also going to continue to monitor for exercise intolerance, fatigue, and heart failure signs. We're going to continue to monitor that split S2 and for any new murmurs. New murmurs are an indication that they are getting worse. When they're getting their catheter, we're keeping them NPO. We're monitoring all of their baseline pulses and doing an allergy check for contrast. If they have had the catheter, we're keeping the leg straight, monitoring the site for bleeding, so looking for hematoma. We're checking distal pulses to make sure that their feet aren't cold, they still have a pulse, because that is how we monitor for proper perfusion. And then we're going to continue to watch for arrhythmias even after they've gotten the catheter. And we're going to support the parents that explaining that ASD is benign and that they tend to have excellent outcomes after that surgery. So, again, ASD is not a medical emergency and they have excellent outcomes. This is something that we have to make sure that we tell the parents because it's scary to hear that your child has a heart defect. We are also going to teach them to make sure that we're monitoring for the signs of increased work of breathing, like poor feeding or fatigue. We're going to emphasize that they have to make sure that they're following up with cardiology even after they've had the surgery. And also remember, this is normal. They can resume normal activity after they've had the procedure. They'll have a normal lifespan after that repair. It's not anything that's going to shorten their lifespan. And after specifically the device closure, we're going to avoid any activity for several weeks. We're monitoring for fever, chest pain, heart palpitations, and they are going to have some sort of endocarditis prophylaxis. We're going to talk a little bit about endocarditis in a separate video, but we're doing it prophylactically because since they are putting a device in a very sensitive area, there's that risk for infection. So that's why we're doing prophylactic endocarditis. All right, these are the resources, and that's it. That's the full ASD breakdown as rapid fire as it can get. Okay, thanks, guys. Bye.